All right, thank you so much. Welcome back, everybody. We're going to go ahead and get started with our next session now. My name is Amber Torres. I'm the chairman for the Walker River Paiute Tribe and the Phoenix area representative for the National Indian Health Board. It is my pleasure to moderate our next panel, which we're going to discuss how Medicare and Medicaid policy can be better addressed through a tribal social determinants of health to achieve health equity. When we talk about social determinants of health, we mean those aspects of life outside of healthcare that influence a person's health. Our first panelist will start us off with a look at how we can better support our elders by addressing those factors outside of healthcare that have significant impacts on health. Larry Curley is the executive director of the National Indian Council on Aging, and is a member of the Navajo Nation with over 40 years of experience working in the aging and healthcare fields. He has worked with Congress, other branches of federal government, and national organizations on aging to develop support for programs affecting elder American Indians. Mr. Curley, I'll now turn the time over to you to tell us more about what social determinants are most critical to focus on in support of our elders' health and what it looks like to approach these social determinants from a tribal perspective. Pijatu, thank you.
Thank you, Chairwoman Torres. Thank you very much for the opportunity. And, I've been in this field for over 40 some years working with different tribes, different organizations around the country. And in terms of the social determinants of health that has an impact on the well-being of older Indian people, there's a whole myriad of issues that faces older Indians as they age. And one of the things is that we tend to look at elderly people as they are now at this moment, like a snapshot of a photo. But a lot of the issues that they end up dealing with in their later years is the result of things that have happened in their earlier years. So we have begun to take a look at it more from a upstream issue rather than a downstream issue. And that is, how do we take a look at, because one of the social determinants of health is education, and that determines a lot in terms of how people learn, how they function, and how they navigate the system. The other is the environment that they grow up in. Too many times we find that there are dangerous things that have happened. For example, on the Navajo where I work, we're talking about radioactive uranium mines that are still uncovered, that are still out there, and that has an impact on the lives of the people. If affected them when they were younger, it's going to manifest itself in their later years. The same in terms of, for example, when I was working up in Nevada, we're talking about arsenic in the water, and that has a cumulative effect over the years. And so that has an impact. Other things just like water, the availability of water, the availability of for example, the broadband, electricity into the house. Those are things that have an impact. And I think one of the big ones is housing. Substandard housing in Indian country all contributes to the whole health status that we find older Indians in. And I think that when we talk about, some of the things that we need to take a look at is I think from a tribal perspective, we tend to take a look at what exists right now. But I think that one of the things that we really need to do from a tribal perspective, and having worked with tribal governments and organizations, is that we need to start taking a look 5, 10, 15, 20 years down the road so that we become more proactive. For example, right now, studies have shown that in the larger non-Indian population, people are going to be diagnosed within the next decade in the non-Indian population with Alzheimer's or related dementia. 1 in 5 will be diagnosed. In Indian country, it's 1 in 3. And those 1 in 3 are going to require caregivers to take care of them. And there's going to come a point in time when that caregiver is the needs of the individual that's getting the care is going to exceed the ability of that individual to provide that care. And so that means we're now talking about institutional care, whether they be assisted living facilities or long-term care facilities like nursing homes. And those are needs that I see happening within the next 10, 15, 20 years from now, and maybe even sooner. And so in Indian country, I think that what I see is that there's a need to begin to take a look at the picture from a upstream perspective. How do we begin to deal with it? How do we begin to start planning for it? Because building a nursing home is expensive, and it is it's something that a lot of tribes think about and say, we want to have it. I know that when I was working in Nevada, Chairman Torres, there was a talk at one point about having a regional nursing home for all the tribes in the region, a 200-bed facility, because that's the number, that's the threshold for it to be sustainable. And this is where the Medicaid program comes in. This is where the Medicare program comes into play, because it becomes almost like 60% of the funding for a nursing home operation. Plus you have all those other areas. But I think one of the things that I've thought about and have tried very hard when I was working in Nevada was, why don't we just carve out for tribes in Nevada a separate Medicaid program specifically for tribes? And that was one of the things that we worked on, but the federal government indicated to us that you have to provide similar services across the state for everybody in the state. But I took the position that we are sovereign nations, and that as sovereign nations, we are a different population, and that we ought to separate out a tribal Medicaid program within the state. But that was something that the federal government from CMS said, no, that's not going to work. So I think that one of the things that we need to continue thinking about is, how is it that we can really take advantage of the Medicaid program so it is applicable to Indian country. There are services that are needed in Indian country. And what I find in a lot of tribal communities is that services that could help to prevent the premature institutionalization of older Indian people are services that could be combined, that could be coordinated. And that whole system, the current word or the current jargon is called long-term services and support, LTSS. And all LTSS means is that the services are coordinated, they're collaborated, that there's a focus on who is going to be served. A major component of LTSS is case management, so that you make sure that people do not fall through the cracks. And when I was working for an area agency in Tucson years ago, when I first started out in the field of aging, we had a programs where there was a central case management program, so that elderly person A needs three units of transportation to a senior center 3 times a week. They need meals 5 days a week, 2 of them to be home delivered. So there was a case, or there's a plan of service delivery that was available, that was implemented, and it worked. And I think that those are kinds of things that we need to begin to take a look at in Indian country, so that we don't have programs that work in silos, that are separated, that we need to bring those programs together, begin to talk with one another, and get away from that territoriality mentality. This is my program. I'm not going to share my information with you. We need to begin to break out of those and begin to look at it on a holistic basis. But that would be my comment on that, Chairwoman Torres, on what we can do, what can be done at a tribal level to begin to think. People say outside the box. Well, in Indian country, and what we say at the National Council on Aging is, we need to begin to think outside the circle. Outside the circle. It would be a better phrase in my view. But anyway, those are my thoughts, and I thought I'd share that with you. Thank you very much for the opportunity.
Again, Pijat, you bring up so many good and imperative points that we need to continue working on. So thank you, Mr. Curley. Next, we will hear from Dr. Kyle Hill on how we can address social determinants to support our people when it comes to behavioral health. Dr. Hill is Ojibwe, Dakota, and Lakota. He is a licensed clinical psychologist and is an assistant professor in the Department of Indigenous Health at the University of North Dakota School of Medicine and Health Sciences. Throughout his education and work experiences, Dr. Hill has developed a multifaceted skill set in decolonizing mental health treatment, trauma-informed practices, health equity, and Indigenous frameworks of health and wellness. So Dr. Hill, I will turn it over to you to tell us more about why social determinants are so important to consider when talking about improving behavioral health for American Indians and Alaskan Natives. Pijat, thank you.
How bonjour. I hope everybody can hear me. Again, my name is Kyle Hill. I'm enrolled in the Turtle Mountain Band of Chippewa and a descendant on my father's side of Siston Wapton and Cheyenne River Sioux tribes. I'm going to share my screen. I have a set of slides to go through, and I'm going to rapid fire because I know I only got like 11 minutes here. But I felt like this would be the best way just to convey the information. Can everybody actually, let me see, I think I shared the wrong screen here. Here we go. All right, so I hope everybody can see this. And let's go into presentation mode. Again, I'm assistant professor at the University of North Dakota in the Department of Indigenous Health and teaching our Indigenous Health PhD programs and our Master of Public Health Indigenous Specialization programs. And so today I just wanted to talk a little bit more about social determinants of health specifically. And in our classes, the way I teach this is, looking at a tree, we have the canopy, the trunk of the tree, and the roots of the trees. And the way we describe those is like proximal determinants are kind of the canopy, the leaves, the branches and such. The intermediate determinants are the trunk, and the distal determinants are the roots of the tree. And the way that we look at that, and especially in relation to healthcare access and quality in relation to the CDC, Healthy People 2030, looking at the social determinants of health, perspective, we'll be looking specifically at healthcare access and quality. But when we think about that canopy of the tree, these are things like early childhood development, income, social status, education, literacy, social support networks, employment, working conditions, physical environment, culture, and gender. Basically, the day-to-day kind of grind that we're on, the organizations, the institutions that we end up running into on a day-to-day basis. And this is really interconnected with the intermediate determinants of health, which, like the trunk of the tree, this facilitates or is an obstacle to health through systems that connect to the proximal determinants. And so this is health promotion and healthcare, most importantly for today's talk, education and assistance, social supports, labor markets, government, and private enterprises. And as you can imagine, our healthcare is really, in a problematic state with respect to the private third-party payers, private healthcare, and then our publicly funded healthcare systems, Medicare, Medicaid, VA, IHS. And so when we think about indigenous intermediate determinants of health, I like what Malia had said earlier. And, in particular, when we think about behavioral health and the impact that social determinants has, we want to think about all of these together. With respect to, in particular, the historical, the legacy of colonial subjugation that we've experienced have really severed our kinship networks, our relationship to land, languages, ceremonies, spiritual connectedness, cultural connectedness, hunting, fishing, gathering, as well as, storytelling. And someone said humor earlier. I think that's a very important piece of who we are as Indigenous people and how we deal with our history, and historical trauma in that respect. And so moving on, when we think about the roots of the determinants of health or the roots of the tree, these are your historical, political, ideological, economic, and social foundations. So we think about the roots of the tree. are the strongest aspect. They provide the base, they provide the ability for that to endure and sustain its entire livelihood, and it communicates to other trees, as we understand. But most importantly, with respect to our indigenous health, the distal or root determinants are that settler colonialism that we've dealt with, right? That's the historical loss, the forced removals, boarding schools, land dispossession, our nutrition transition, which is responsible for the diabetes disparities that we've experienced in relation to commodity foods and subsistence from the government. But these are most importantly, not only are they interconnected with the proximal and intermediate determinants, these are the most impactful. And when we think about public health programming, it's at this level that we want to affect change in our communities. How do we impact the distal or root determinants of health in our communities with any decision that we make around healthcare programming, right? And we already know we face so many, we have so many disparities in social determinants with respect to lower life expectancies, higher unemployment rates in our communities, lower incomes, poor educational attainment, certainly psychiatric disparities or psychological disparities like PTSD, anxiety disorder. The epidemiological evidence is murky a little bit, but depressive disorders trend to be a little bit higher. Substance use disorders, and of course we have suicide. The prevalence rates of suicide are higher. And this is, if you look at the IHS Trends book from 2014, these suicide prevalence rates have been high since the 80s. And that's almost the earliest where we can see some of those epidemiological those rates or data actually coming forth in those ways. And then, of course, we have health disparities, diabetes, obesity, substance use, suicide, unintentional injuries, cervical, kidney, and liver cancers. And so just to shed light a little bit about our service system, of course, everybody knows this probably on this call. Of we have our IHS facilities, our tribal facilities that have 638'd or gone through that, they're administering their own services, as well as the urban services that we have. And so the IHS mental health social services program is typically an outpatient mental health counseling program where you can access oftentimes dual diagnosis services, which is very important for, we often don't have one disorder alone. We often have multiple, and that goes with physical and mental disorder issues. So, for example, comorbidity with diabetes and behavioral health, that happens to occur more often than not. So we have that ability. We have case management services, community-based prevention programming, outreach, and health education activities. But importantly, I think we realize also that the Indian Health Service is tremendously underfunded. And here you see, the healthcare afforded per capita in the IHS is much lower, than veterans or those who receive Medicaid, or even those who receive federal health benefits by their employers. So there's certainly a disparity here. And so this would fall in line with what we looked at earlier in terms of like an intermediate determinant of health, right? We don't have the healthcare access that we need. And so when we think about behavioral health and the impact, we really need to focus on those distal determinants of health. And we could most effectively do that by thinking about decolonizing our behavioral health within our communities. And I know this font is really small, but essentially what that means is returning to these original instructions or traditional teachings that we've had in our communities, because we understand that our cultural connectedness, spirituality, that might mean engagement in traditional activities, language, as well as, just identity as Indigenous people is very important for prevention of many of these types of disorders. So instead of taking a, downstream intervention approach, when we utilize our these traditional ways inside of our offerings, within our communities, it's going to have more prevention capacity, right? So we're not having to deal with so much suicide at the back end of what typically happens, and that's an extraordinary cost. And so what is a decolonizing behavioral health? We think about land-based healing approaches. I think, again, to what Malia and Dr. Villegas and Dr. Braveboy said, Indigenous epistemologies. So think about, how do we utilize our ways of knowing, our original instructions to guide our healing modalities, as opposed to relying on evidence-based practices such as cognitive behavioral therapy, or other types of approaches for any of these types of disorders, utilizing trauma-informed care and infrastructure, because we understand that our people have gone through so much, that the trauma of having to even go in the Indian Health Service, when we know there are associations with the sterilization of Indigenous women or American Indian women as recently as the 60s and the 70s. This is all problematic. Having doctors that don't look like us, or providers that, when I was working for IHS, we did something, a contract service called locum tenens. And so it was, inevitably it was a non-native, often white, whether it was a nurse practitioner, a nurse, or a doctor would come in, there's a fundamental mistrust for our institutions for a reason, and this doesn't help us. And then, of course, honoring tribal sovereignty and self-determination in any healthcare decision-making process. Again, important staffing decisions, and developing a almost like a formulary of practice-based evidence, so that we can look at how our ceremonies, or how these preventative approaches embedded within our cultural and community systems are going to facilitate healing. And then this incentivizes 638 programs to tribally administer and use the Medicare and Medicaid expansion in innovative ways, within the Indian Healthcare Improvement Act. And so some of what has been mentioned previously in materials has been engagement of traditional medicine and other cultural and embedded treatment modalities in our clinics and offices. And then again, entering into agreements with the VA and sharing healthcare services for American Indian Alaska Natives. And again, this was expanded under the Affordable Care Act. And so that's it for today. I really appreciate everybody for listening. I will stop sharing my screen and just take questions. Miigwech.
So we're actually going to ask that you hold off on your questions, and then we'll get to all of those after the third presentation here. But thank you, Dr. Hill. That was excellent and so needed. Thank you for that good medicine and sharing this morning. Our third panelist is Miss Mattie Curley. Mattie is an enrolled member of the Blackfeet Nation. She has been at NAHB for 2 years and serves as a project coordinator in the Public Health Policy and Programs Division. She has a Master of Public Health degree in Maternal and Child Health from the Colorado School of Public Health. So Ms. Curley, could you tell us more about where we should focus our efforts when it comes to improving health outcomes for Native mothers? And also, what are some of the needs or barriers women face that can get in the way of healthy birth, pregnancy, and postpartum care?
Thank you, Chairman Torres. I am honored to be here today. I am humbled to be in all of your presence. I know you were promised Cecilia Fire Thunder. Unfortunately, I am not her, but hopefully I can fill some space in her large shoes, and provide you with a little bit of an overview on maternal health in Indian country. Kyle did such a great job going over our social determinants of health and all of that, that I'm going to kind of step away from that, because that was such a great presentation. So thank you so much for sharing that and sharing your knowledge with us. So just briefly, I wanted to go over some CDC statistics for maternal health. Native women have a pregnancy-related maternal mortality rate of 29.7 deaths per 100,000 live births. And this is really just going over these statistics to provide context for what I'm about to discuss and the points that Amber asked about. So in 2019, Native mothers were almost 3 times as likely to receive late or no prenatal care compared to white women. Infants from mothers who do not receive prenatal care are 3 times more likely to have low birth weight and are 5 times more likely to die during infancy. The infant mortality rate for Native peoples is 2 times higher than white people. Native infants are also 2.7 times more likely to die due to maternal complications than white women and white infants. Over 90% of Native births occur outside of an IHS facility, and Native women are 20 times more likely to give birth at a hospital without obstetric services and had less access to obstetric care. And then finally, 21% of Native women are currently uninsured. So with those statistics, kind of what barriers affect American Indian and Alaska Native women who are already at a higher risk of maternal death. Pregnant people who are unable to receive care, we know, are at a higher risk for pregnancy and postnatal complications and severe maternal morbidity and mortality. There's also implicit bias and racial misclassification, which Kyle talked about, which results in reduced quality of care and data discrepancies, which results in data misinterpretation and misrepresentation. That leads to, also contributes to reduced health equity. Again, due to historical trauma, history of forced sterilizations that ended very recently, boarding school trauma, all of those generational impacts has led to a mistrust of providers and reduced patient retentions. And then also, again, Native women are 2 to 3 times more likely to die of pregnancy-related complications than white women. This is the second highest rate of maternal mortality in the US. However, the issue of maternal mortality in the US of Native maternal mortality in the US is often considered invisible. And because conversations are mostly focused around other minorities, and resources need to be equitable for all groups, as Native people are also severely affected. So what is contributing to Native mothers not being able to receive care on their tribal lands? Again, this has been talked about a lot, but limited funding, the IHS being consistently underfunded, and programs that have been maintained for years in Indian country are at a consistent threat of being cut. For example, SDPI, visitation programs, all of those programs that support Native mothers in their health. Again, low provider retention, so rates for AI and non-AIAN providers in tribal-based health clinics is low due to barriers and unfavorable conditions in health clinics. There's also a limited number of Native OBGYNs. Numbers in the US that you might be seeing are falsely high due to issues of self-identification and self-reporting. And then there's also a limited training pipeline. So again, increasing access to providers and increasing provider retention is difficult when Native providers are consistently facing bias and racial disparities within their programs. So in order to address some of these inequities, there's growing advocacy among Native women to shift towards alternative models of care that emphasize patient-centric care and recognition of lived experiences. Recruiting and retaining Native clinicians and caregivers should be a priority to reflect the communities they serve. Continuing education that encompasses the unique strengths and challenges faced by tribes should be developed in collaboration with tribes and made widely available. There also must be an exploration of the role that trained community health workers, doulas, trained birth attendants, and community members can play in delivering culturally relevant maternal care without requiring a higher education and degree, again, to break down those barriers that colonization and education place on traditional birth work. Increasing focus on a woman's clinical and non-clinical experiences in pre and postnatal care and the expansion of the maternal health workforce might support the development of culturally relevant, respectful, and relatable birthing opportunities for Native mothers. Again, investing in culturally competent care, providing increased support for tribes interested in revitalizing their traditional knowledge around birth, and reaffirming sovereignty by delivering on tribal homelands. And then also providing additional support for women to receive care. For example, travel support. Women often have to travel hours to receive care, which can be extremely difficult in their third trimester as it's getting closer to delivering. And bad, they could be traveling in bad weather and things like that. There needs to be more resources provided for these women to receive the support they need. So that's a couple of my recommendations. Again, I apologize for not having slides ready. But that was just a brief overview. And again, thank you for your time. I am honored to be here, and thank you.
Appreciate you again, just bringing all those things that we historically know to the light, but we need to continue to work on, most definitely. So thank you for that, Ms. Curry. So let's continue to dive into some of these ideas a little bit deeper. Dr. Hill, if we could we start with you?
Yeah.
Okay, perfect. What's distinctive about a tribal perspective of social determinants of health? Second part of that is, what's most important to keep in mind that might be different from other contexts where people talk about social determinants of health?
Yeah, I think social determinants of health is a really important set of, I guess, I want to say like principles of health or prevention that I feel really advocated or provided a place for Indigenous people to discuss the impacts of historical trauma. Previously, like, historical trauma is not recognized as like, a syndrome or anything like that, because you have to experience some sort of trauma firsthand or vicariously, but it has to happen during your life course. And so I think the social determinants of health from an Indigenous perspective, if we're talking about the risks or the actual negative impacts of that, are really important, because it allows us to really call to action the very direct impacts of systemic oppression, systemic and structural racism that are really founded upon, this white supremacy, in our nation, in our communities, right? That impacts all of our lives, like so much, right? If we boil it down and just go down to healthcare access and healthcare equity, I can think about things as a provider that we had to run up against firsthand. One of which that comes to mind right away is thinking about how we diagnose mental health disorders or psychiatric disorders all the way down to childhood, thinking about ADHD, right? And so our states would often mandate the use of these instruments and tools, these cognitive batteries and measures that often didn't include any type of like culturally sensitive items. They were often very Western in the way that they were embedded and the weights that they were measured on. And so I think first and foremost that, but I think most importantly for, when we think about those teachings of like 7 generations ahead and how we organize around the land, right? Thinking about how we are the land and the land is us. I think when we think about social determinants of health, I brought up the intermediate determinants from Indigenous communities is like really elevating those kinship networks, not only between ourselves within our at the family level, but also in our the ecological level with our like non-human relatives and community members, And so I think that's the benefit and the real strength of looking at social determinants. So yeah, I hope that answered your question. I know that's kind of a lot, but that's the best I got right now.
No, that absolutely answered it. I appreciate that and give us a lot to think about and grow on. If we know better, we need to do better. Would any of the other speakers like to add on to that? Mr. Curley, Miss Curry?
Could you repeat the question?
Sure. What's distinctive about a tribal perspective of social determinants of health? Second part of that question is what's most important to keep in mind that might be different from other contexts where people talk about social determinants of health?
Well, I think that from a tribal perspective, we have a history that we've lived through. And as Dr. Hill mentioned, he mentioned all of those issues that we have gone through, that we have lived through. And I think that the important part of all of this, and when I see our elders, and there's 503,000 of them now in this country, they to me represent resilience. They made it through a world that was hard on them. And I think that in terms of, from a tribal perspective, social determinants of health, there are other areas where the non-Indian population does not understand. And that lack of understanding is the concept of tribal sovereignty, that we control our own lives and that we should be able to determine for us what is a research topic, what is a worthwhile research topic, rather than them, the federal government or whoever, determining what a research agenda is. We're interested in looking at this, they say. And so we have tribal researchers who go out and try to do the research that those non-Indian researchers want to know, rather than us trying to say, this is our research agenda, this is what we want to know, rather than being steered in a particular direction. And so to me, that's one of the things that in terms of social determinants of health, in my view, is the lack of data. If we had data that was accurate and generated by tribal researchers, we would be able to interpret that in our own way so that we can begin to talk about evidence-based programs from a tribal perspective. And I think that that's part of the fallacies of the larger societies looking at us and trying to group us into other populations of color. We have that difference, and that difference is the fact that we are in Article 1, Section 8 of the United States Constitution. That's the difference. And that's what and from a social determinant, that's what makes us different. So that's what's tribal definition of the determinants of health is different, that we see all of these issues, all the results from what Dr. Hill mentioned. The whole era from 1492 to here has created a world that really has been detrimental to Indian country and to Indian people. And that's how I would respond to that particular question.
I did want to say something real quick just to wrap this this question up. When I was working for IHS during the Trump administration, what really, I think, opened my eyes to the power of the social determinants and the impacts on our healthcare that we draw as Indigenous people or American Indians, Alaska Natives. When the shutdown happened in 2018, 2019, that shutdown, because the Indian Health Service draws its appropriations from the Department of the Interior. The Department of Interior was the only federal agency to shut down. So if you all remember, the parks and stuff like that were a mess. But it only impacted disproportionately in American Indian, Alaska Native people. And so I don't understand how that's not a civil rights violation if we do have a right to health, because we went unpaid and we were forced to work, which is crazy. That was such a stressful time, but so that we can keep our health system going within IHS. And so I just wanted to mention that real quick, because that was, I think, the most powerful experience for me in terms of understanding how powerless we are, I guess, in this system, right? Because it was really tough, and we had providers in a bread line, we had people at the hospital getting in line to get bread because we weren't getting any money, right? So it was that crazy, and I'll never forget that.
I appreciate you bringing that up, because I think, as a tribal leader who's the voice sitting at these tables, we have so much more work to do, and you just by sharing that story and bringing up that historical trauma time of, closing down and what everybody went through, is you definitely fueled my fire once again. So I appreciate that. Ms. Curry, did you happen to have anything that you wanted to elaborate on?
I think Mr. Hill and Mr. Curley, Curley, that's kind of fun. I think they pretty much
you guys are
covered
confusing me.
It's important to know that, as Native people, we hold tribal sovereignty and we know what works. So we need to be the ones that have that knowledge. So
absolutely, definitely. As we continue the conversation here, I'd like to hear more about what it looks like to take a holistic approach towards health and wellness for our Native people. Mr. Curley, could you share some examples of how tribes and tribal organizations have gone about caring for elders in a holistic way, caring for the whole person?
Well, again, one of the things that we take a look at is that from a tribal perspective, we're not, the spiritual is on one side, the mental is on one side, the body is on one side. We are one whole person, a total person. And so when we start talking about working with elders in tribal communities, we need to continue to look at them as a whole person. What do we do to meet their spiritual needs? What do we do to meet their physical needs, their mental well-being, their economic well-being? All of those are factors and to consider as we move forward in addressing those issues in a holistic way, not in a fragmented way, but in a total person perspective at one time in one place, so that we treat them at the moment they need it. And I think that there's this concept that we keep talking about called long-term services and support, LTSS, which is essentially an approach where you bring all of the different programs and services in a community together to collaborate and to make sure that services are provided to the most vulnerable population within a tribe, which is our elders. And there are examples, for example, Zuni Pueblo in New Mexico has developed and implemented that particular kind of a program where a comprehensive approach to the needs of older people are there. The housing department, social services, law enforcement, the hospital, they all collaborate and make sure that an elderly person receives the services in a timely basis through a case management system. That's one tribe. Another one is the Oneida Tribe. The Oneida Tribe has a fantastic looking program, which is similar to what Zuni has done. They have implemented that program. It has been around for quite some time. And another tribe is the Cherokee Tribe in Tahlequah in Oklahoma. They have a similar kinds of program, and they have been working on that particular system, and it's working. And I think it's a matter of tribal leadership saying, you will work together. You will make sure that you collaborate with one another and do everything possible to make sure that these services, that you develop the cooperative agreements between the different programs and begin to share your staff, share your resources, so that you have a comprehensive approach to the needs of our elders. Because I guess this is just my own personal view. Those older people still have our language. They still have our customs. They still have our traditions. They have our history. They are our walking encyclopedias. You know, the mission statement of National Indian Council on Aging is to advocate for the economic, physical, and social well-being of older Indian people. That's what we do. But the question that I've asked is, why are we doing it? And the answer, in my view, is because through these elders, our traditions, our language, our culture, everything can be brought forth to train our young people, educate our young people, so that 2,000 years from now, Walker River Paiute tribe still exists. That's what our elders represent to me. It is the survival of Indian tribes. And that's how I say how when you develop programs, make sure that we capture every bit of that older individual and what they know, and make sure that it's captured and utilized for future generations. That would be an example of some of the things that are happening out there in Indian country.
Thank you. Thank you so much for that. Such wise words. I was going to ask the other two participants that same question in their respective fields as far as maternal health and behavioral health, but I did see that we had a question from the audience, and I wanted to respect that. Did we see where that individual had went to? There are a lot of participants on here today, which I'm very, very excited for. And the conversation is good and it's meaningful. And I think the best practices that we're sharing are phenomenal, but I definitely don't want to overlook somebody who had a question.
Lakeisha?
Do you want to ask your question? You just take yourself off mute
Thank you.
down on the bottom. She had it raised and then maybe left, so guess we'll move on.
Okay, so I do want to allow Ms. Curry, if you could tell us what a holistic approach to maternal health would look like. And if we do it briefly, so we can open the floor up to our to all of our people.
Sure, yeah, I can be brief because I think Mr. Curley really covered it, and those important things that he listed also apply to our mothers, infants, and children. As the birth givers, as the givers of life, we need to prioritize their needs first, and then this all goes into the holistic realm of kind of the clinics, services, and community and data. But then there's also the need for policy advocacy at the national level, because we are, it is the double-edged sword of, being oppressed by the government, but then having to receive funding from the government. That's really the fine line of where we can step in and advocate, and get bills passed through that do support mothers and support increased funding for programs and, federal institutions and those sort of things. So yes, just briefly, I wanted to add on just that policy piece as well.
Thank you. I appreciate that. And Dr. Hill, is there anything more that you would like to add about the holistic approach in regards to behavioral health?
I think the most important thing that I can think of is, how we start to reclaim and what that looks like, while also, trying to figure out ways to reimburse our efforts at the community level. And I know that's really hard. Like, I was at a clinic previous to my academic position, where I was the clinical training director, and we worked on a lot of decolonizing mental health initiatives, indigenizing, all of these things that we hear. But when it came down to it, one, we had issues with HIPAA because you can't be seeing with a patient, which is problematic because if you're in a community, it's not like you have that privacy all the time. And so there just needs to be really important shifts in these policies, whether it's privacy and some of these other regulatory issues around like evidence-based practices versus practice-based evidence, and how we reimburse for those, because you can't, it's almost like mutually exclusive. We can't be sitting there and having like a watchdog say, oh, Dr. Hill is taking his, one of his patients out to the river to do X, Y, and Z. That's a HIPAA violation. You know what I'm saying? Well, at the same time, we're sitting here preaching like we need to decolonize, we need to reclaim our ways, we need to bring language into the, and so there just needs to be a really a reckoning, of our health systems as Indigenous people, how we're administering them, and the regulating bodies that we have to adhere to. IHS, for example, like we couldn't even smudge in the building. Like that's problematic. Like, how can I work for Indian Health Service and not being able to smudge? Like, to me, that's just so. And I think that's where you see that level of, hopelessness set in and helplessness, where it's like not even our own health systems can manage to deregulate so that we can start to reclaim these traditional practices and in very like small ways, incrementally, to get to a place where we're just realizing like what Mr. Curley said about, really starting to develop, and we're all relearning. So that's pretty much all I would say. It's just a tough place, but I think we're actively, people are figuring it out, but it's like obstacle after obstacle in these bureaucracies.
Yes, thank you. I appreciate you sharing that insight. We do have that question from the participant from earlier, Lakeisha Owens. She says, modern research has been conceived with Western practices. How can we learn to integrate and marry the two customs to produce a significant, I believe it's release of information? It says two practices being Native and Western practices.
Return on investment, is that what
could
it
be?
yeah.
Marry the two customs to produce a significant ROI.
Yeah. So in terms of like research, and we look at this in one of my classes too, it's called like a two-eyed seeing approach. And apparently this is like an Indigenous approach that is, from a long time ago, but it's this approach where you utilize or harness your Indigenous kind of epistemologies, your way of knowing, your ontologies, like how we know we exist, your being, values, and then you take those best Western approaches and you kind of like integrate the two, and so I think that that's the best way to move forward now. And especially much of my work now is in like climate change and Indigenous health. And I think moving into that space of work, I don't think there's any other place where you realize how important it is to have like an interdisciplinary approach to the work. Like you need scientists, you need ecologists, you need geographers, you need, social scientists or psychologists and you also need like traditional practitioners and language people, because all of that like land-based healing and the ecological like restoration, like it's so interdependent, and so I'd say like that's like probably the best example I have, when we think about all the land dispossession, the dispossession of all the things we were dispossessed of, that we're just now trying to reclaim and so thank you for your question.
Yes, so thank you for that. And what I wanted to get into is when considering these topics of elder health, behavioral health, and maternal health, Medicare and Medicaid are the largest funders of these services in the U.S. From your perspectives, what are some steps that Medicare and Medicaid should be taking to ensure holistic care for American Indian and Alaskan Native people? And I'll let each one of you answer. Mr. Curley, if you want to go first.
Yeah, I think with the Medicaid program, we have a program that really are fragmented from state to state to state. And so you have, just as an example, Arkansas has their own Medicaid program.
Mm-hmm.
Then you look at Oregon, they have their own Medicaid program. They all have different benefits. And then there are states who took advantage of the expansion. And it's interesting that the states that have the large Indian populations did not do the expansion. And so those are some of the barriers in terms of the Medicaid program. But I think that one of the things I was saying earlier is that I really think that the Medicaid program needs to take a look at tribes as sovereign nations within a state and have the tribes develop their own Medicaid program to meet their needs. When I was working for the Navajo Nation, we asked DHHS to provide funding to do a feasibility study so that we could see if we are ready at Navajo to take on our own Medicaid program, because we were in 3 states, Arizona, New Mexico, and Utah. So even the one reservation with one population was having to access 3 different Medicaid programs, all different with different kinds of benefits. And we wanted to consolidate, have our own Medicaid agency. And when the study was done, the feasibility study was done, the study indicated that the Navajo Nation was ready to manage and administer its own Medicaid program. Unfortunately, things change in terms of the politics. I was a political appointee, and I don't know where that is now. But I think that those are options and possibilities. When we talk about tribal governments that have 638 their programs, their self-governance tribes, especially those that have done the Title V, compacted their programs, that money loses its identity. The tribes could reprogram those funds to provide services that are most needed at the tribal level and meet the needs. And from my perspective, for example, it would be really cool to have those tribes who have Title V compacts to sit down and begin talking about an LTSS system at the tribal level, because that money no longer is there, is earmarked anyway for any particular service. I keep hearing that LTSS or the IHS does not provide funds for LTSS or long-term care services. But if the tribe compacted it, it's very possible they could do that if there is that need. But for me, that's how I look at how we can begin to talk about improving the system. The other thing too is that every state, every Medicaid program, since they're different, have different encounter rates. I remember when I was working in Nevada, a person coming in from, what was the name of the tribe that was over the way over there, outside of Fallon? Yamba. People were coming from Yamba to Fallon, to the clinic, but we could only charge for one service per day. But we ended up talking with the Medicaid program once we found out that there were other states that were doing 5 encounters per day per patient. And we finally ended up negotiating with the state of Nevada to have at least 3 encounters per patient per day. And so those are things that I think that if they understood the topography, the infrastructures, the roads, all of that stuff of a tribe, that they could say we should have a standard encounter rate for Indian tribes across the country. I think that that's something that we could take a look at.
Dr. Hill?
I thought that was brilliant. I mean, what Mr. Curley said in terms of recognizing the sovereignty and nation-to-nation relationship and allowing our own tribal communities to develop their own Medicaid or Medicare programs. That'd be amazing to see. And I also think, you know, the offsetting that the cost of Indian health service, like I think finding more innovative ways to do that, you know, especially with respect to behavioral health, like, you know, we're able to enroll because a large number of American Indian folks fall under the poverty line into Medicaid specifically. And so therefore we can utilize those funds. But I mean, I don't really know enough about how that reimbursement, you know, is the regulations that govern that reimbursement to Indian Health Service programs. So I don't know if it's like a one-to-one where, let's say if there was a traditional medicine or traditional healing or land-based healing program by one of our 638 facilities, would Medicaid or Medicare reimburse for that had a patient wanted to get reimbursed through, you know, through Medicaid as opposed to IHS, you know? And so I think those are some questions that would really need to be answered, because you're not using an evidence-based practice, you know, per se, you know, but you're using a really like local community-based practice that's, you know, been well recognized to improve the health of the community. And so that's something that I would like to see, but I don't know enough about it, to be honest. And I think that would be the most important kind of innovative thing that I think would be helpful.
Thank you both.
Mhm.
Let's see, Ms. Curry, there's a question in the chat from you. I'm sorry, for you. Mattie, what are some of the ways that CMS can include traditional practices for birthing women to improve the Western medical perinatal practices?
Sure. So I thought a little bit about this question. I saw it in the chat. It's a great question. So I think that the conversations that have been happening lately around increasing traditional birth knowledge and revitalizing the Indigenous doula workforce would be a way to blend kind of the Western medical model along with our traditional birth models, as well as increasing coverage, expanding and including doulas and traditional birth workers in CMS coverage, if that makes sense. Also, I think, you know, just as another side note, expanding parental leave programs would be extremely important. And I think Medicaid only covers 60 days post-birth for patients. So being able to expand that, because 60 days is really nothing. That's 2 months. That's, you know, you're still trying to figure it all out within then. And yeah, so again, including, you know, traditional birth workers, I'm seeing lactation care as well in the chat. That, you know, falls into kind of the realm of traditional birth knowledge, and really just emphasizing the importance of that is my recommendations.
Could I add something to that? One of the things that I know about the Medicaid program is that for every individual that goes through an IHS facility or through a tribal compacted facility, 638 facility, that the state has, the state has a FMAP matching program. And some states have like 50%, 60%, 70% that the state has to put up, and then or 30%. But every time an Indian person goes through an IHS facility or a contracted facility, the state doesn't have to put up that money. It doesn't spend its money. What could happen, and I think some tribes, some states are doing this, is that money that was saved. When I was in New Mexico, I was working in this one hospital, and by looking at the ICD-10 codes and the CPT codes that went along with it, the cost for providing that care was $12 million in 1 year. And that $12 million, the state didn't have to put up the 30% match. And so what I was asking is, why not return that 30% back to the tribes, back to where the service was provided, so that then at that particular point, you can do the traditional birthing and the traditional psychological counseling processes, so that the tribe can utilize it the way it wants to. So, that was just a thought that I wanted to share with you all. Thank you.
Thank you. At this time, I see a lot of conversation going on in the chat, and I'd really like to open up the floor for all of our participants to be able to ask your questions of our panelists today. And I'll go ahead and call on you, Mr. Cannon, if you want to go ahead and get started. Thank you.
Thank you for the opportunity, and thank you for this great experience here. It's been awesome. I really appreciate it. And Mattie, kind of speak to what you just talked about creating these opportunities and these infrastructures in place. And Mr. Curley, you kind of hinted to the idea of this, and you've seen, I think all of us who's been in this infrastructure, knows its strengths and knows its weaknesses. What I'm leading up to is that it would be heartbreaking if you got all these programs in place and everything was in place, and all of a sudden your Native women who stepped up to the plate, did the certification, the schooling, all of a sudden they weren't given the job and it was given to someone who was non-Native. Because what's happening now, there's a lot of Native businesses in this arena that are making an effort to work with this. And in fact, they have the Buy Indian Act, which we all thought would be phenomenal. But we're actually seeing Native entrepreneurs being pushed aside to continue to work directly with other non-Native businesses directly. Even though it's the same product, even if it's at a cheaper price, they don't have that. So I think one thing I love to bring to the idea, I think there's no one on this panel, but if I could just bring it to the whole, everyone in the presence here, is the idea that we can start building these infrastructures and these ideas now. So when your program comes in place, it fits right in, because there's a lot of Native entrepreneurs who try to get into this field, which is a great field to be in, but they just find themselves hitting walls, just even though they're Native and they're a Native-owned business, and they're trying to make that effort, they hit their own walls with their own people. So it's not a perfect system, but I would love to see more support from the higher levels, which they're already trying to do from the Buy Indian Act. And there's this mid-level that people who actually support and keep that dollar with Indian country. Mr. Curley, you said to think outside the circle, not the square. And I think that's absolutely true when we talk about keeping that dollar in Indian country in all aspects, not just within education, profession, but also the economic development arena. If we can keep this whole circle involved into one in Indian country, we would be phenomenal. If tribes could all team up together and buying big purchases for medical devices, that would be huge. But it's just, again, it's a big wish, and I hope someday we'll get there. If we do, it would be phenomenal. Again, I thank you for everyone sharing your thoughts and the previous speakers as well. So thank you.
Thank you for sharing your question. Again, we've got the floor open to anybody who would like to ask questions to our panelists.
Yeah,
While
someone in the chat said, can you speak about how this Carolyn Arteaga, can you speak about the focus on funding evidence-based practice interacts with efforts towards decolonization, and can these efforts coexist? And as far as I know, the term evidence-based practice and the evidence needed in order to categorize something, a treatment approach as an evidence-based practice, is governed or regulated by some of these like institutions or organizations or regulating bodies. For example, like the American Psychiatric Association, the American Psychological Association, the American Medical Association, and such. And so according to like the APA, for example, they put out what was called like a Task Force 12. It's an old kind of document, but it essentially says you need one clinical trial and two quasi-experimental studies in order to classify your treatment approach as an evidence-based practice. It was something like that, okay? It may not be that exactly. But of course, that's a barrier for our communities that, one, don't have the research infrastructure, but two, there's a fundamental distrust or mistrust in research institutions, the places that have that infrastructure and resources. If we look at even the Havasupai, that ethical, like huge, irreparable disruption for that community by ASU. So that's the issue, and so that's what's standing in the way of getting our decolonizing efforts into those types of, I want to say, like formularies, because it really is. It's like when the doctor gives you a prescription, you go and you draw that prescription from the pharmacist. It's the same way you go into like a psychiatrist or psychologist's office. You come in with and even the criterion that our disorders are categorized into, the diagnostic manuals, those are developed by Western, institutions too. So you see that they're developed, within this like capitalist system so that certain people or certain institutions can get revenue from these practices. And so the whole issue behind decolonizing mental health is, one, recognizing that that systemic issues and the racism there, and then two, finding ways so that our treatment approaches, whether that's like land-based healing, traditional or cultural approaches, can be resourced and used in our communities too, right? And there's a lot of literature on that, but yeah, it's a problem.
Okay, Mr. Roberts, I see your hand up.
Yeah, thank you, Chair Torres. And I appreciate the panel being here. This is a very great opportunity, and the panel before was great as well. So I really appreciate you all being here and discussing these. I want to come back to the context of kind of CMS programs, and I put into the chat box the definition that is in the CMS's health equity plan. And I don't mean to necessarily call out CMS on this, but just generally speaking, from federal health programs or federal agencies, as they kind of define health equity, and then kind of how that that definition gets moved into other policy types of decisions. And we heard Dr. McIver talk about kind of the pillars of health equity and the framework that CMS has. But I'm just wondering how you all feel, and it gets back to the point, Mr. Curley, about the fact that, there's unique kind of policy recommendations we're making to the agencies to address kind of the health equity needs for Indian country. And I think the challenge is, we get caught up in kind of the framework of those programs, in that they have specific either statutory or regulatory requirements that, comparability of services, at least in the Medicaid program, that have to be statewide, or freedom of choice for, accessing care for tribal beneficiaries and also willing providers to provide those services. And my point here is it gets back to kind of the very early discussion that we had with the opening speakers that talk about the political and legal relationship that the United States has with tribes. And I'm just wondering what your reaction is to the definition, because I think in one case, maybe even including a reference to, just opportunity somewhere in here that talks about race, ethnicity, and disability, but also political status or something that relates to politics. I mean, on its face, how can you argue against this definition? It's broad, it's good. I think it covers most issues. But for us as Indian people, I don't know that it covers the things that are important for us in order to provide kind of the policy basis for how a federal agency might deal with these issues with respect to some of the things that Mr. Curley talked about. So you might be able to do that if you inserted the term political or kind of legal in some way, and that that gets at some of the things that Mr. Curley is asking the agency to do, or CMS to do. Because once you insert that political reference or that legal reference in there, then it provides the policy basis for how those decisions or issues are made. And that's that you can treat Indian people differently with respect to federal programs, because you're advancing a unique political relationship that federal agency has with tribes in dealing with Indian people. So I just wanted to see what your reaction was to this definition, and to see if does this work for you, or did you have, and I know we'll have more discussion about this later on. So I just kind of wanted to see or hear what your reaction to that might be. Thank you. I know there was a lot there. Appreciate your work, Chair Torres.
I think that one of the things that we keep hitting away, and a lot of us have been doing this for years and years and years. I see Ed Fox up there, and I see you there, Jim. A lot of these issues in terms of just looking at it from the point of view of tribal sovereignty, working from within that framework. And that really is, like you say, it's a political statement. And that this particular definition, while broad, it's all encompassing, it still does not take into consideration the uniqueness of Indian tribes and that federal government to government relationship. And I think that that's something that in this particular definition of equity needs to include that particular statement as well, that particular word anyway, to be included in that. A lot of the equity stuff that we're looking at, that we talk about equity, is that you have some measure that says, oh, we have reached equity. But what is it that you're looking at when you talk about equity? It's numbers, it's data. And how are we getting that data, and how is it being interpreted? And so it all comes back down to the research stuff that Dr. Hill was talking about earlier, is that the data, that's how it's interpreted, is driven from the outside and how it's being interpreted. For me, data needs to be used to be translational, to transform policy. And I remember back in the early 80s when the Older Americans Act was passed, we did a research study that looked at how are Indian people, in terms of being socially, economically, physically, how well are they compared to the non-Indian population? We took the non-Indian research instrument, we changed it a little bit so that it would fit Indian country, and we trained Indian people to be interpreters and translate the instrument. When it was all over with, what we found was that Indian people at the age of 45 were exhibiting the same characteristics as a non-Indian population did at 65. The Older Americans Act was changed, modified, amended, so that Indian tribes determined what elderly means within their tribe. There was no number. And that's how, to me, data should be used, is to change policy so it fits Indian country. But in response to your question, Jim, I would agree that something like political standing should be included in that definition.
Great. So again, thank you all for joining us today. I want to thank the panelists for all the conversation, the best practices, the recommendations, and just the information overall. I think this was a very meaningful panel, and just appreciate all the inclusion and sharing the space. Very honored and blessed to sit with all of you today. So Pijat, thank you. And this will end our panel for today. Good to see you again. Take care.